Thank you all. I'm Laura Clemenson, just in case you were wondering. That's Louis.
We kind of look alike.
Yeah. Thank you for carving out time this evening for this to meet Louis and have us have a conversation about his book. We totally appreciate it. And thank you to the library for inviting us and hosting us this evening for this important conversation as well. And thanks to Louis for getting on a plane, getting up at 3:30 this morning. I do have to say, so getting on a plane from Minnesota, and a couple days ago, sorry you didn't know I was going to say this, a couple days ago he's like, do you want me to catch the bus? I go, yes. I'm like, what a gracious man, so thank you.
Sure.
I want to start off just kind of talking about how I even found this book. This is one of those instances, everybody can hear me okay? This is one of the instances where the algorithm is my friend. All of a sudden on my phone, I start seeing Louis talking about end-of-life choices, and he's a cardiologist. I'm like, who is this guy? And how is it that there's a cardiologist that wrote a book about end-of-life choices? That doesn't even make sense to me. And so I was a little cynical, and I bought the book, and I have a little private conversation with myself, and I'm like, I'd just be willing to be surprised. I started reading the book, and I'm like, this is, I think, one of the best guides that exists out there. And I read a ton, I see a ton, and so I emailed him, Pre-Dead Social Club at Gmail. I'm like, we'll see if he opens that. I got a response. And so anyhow, we ended up emailing back and forth. And I said, can we just hop on a call? And he's like, sure. So I'm in a parking lot at Target. I'm like, this is when I can talk to you right now. And I said, before we get into anything, I just want to share a perspective with you, and I would love to hear what your perspective is. And he's like, sure. I said, all right. If you pulled me from a burning building, I'm going to say you saved my life. If you fixed my diseased heart, wherever that is,
in the middle,
I'm going to say you've extended my life. I'm curious to know what your perspective is. And you said?
Well, I don't remember exactly what I said, but it was something similar to that. Yeah. I mean, extension of life with quality of life attached is a significant improvement. Extension of life without any quality of life, what's the point?
Right. Yeah.
So.
Yeah. So that's when I said, can you come out here and do an author talk? I think I got some people that would be interested. So let's talk about your book. For folks who have not read it, it's not a storybook. It's not a book of a bunch of anecdotes or vignettes. So for folks who haven't read it, what should they expect if they were to purchase it?
It's a workbook that will walk you through how you need to start thinking about your end-of-life choices. We talk about statistics. I talk about the quality of life markers that I think are important, and that's a table in the book that's based on what my patients taught me. Then we talk about all the specifics, a basic outline of what happens if you get rescued, and what are the potential advantages and disadvantages. We then talk about power of attorney, how to go about and do your healthcare directive. And actually, at the end of each chapter, there are questions that you go work through and answer. At the end of the book, I think it's chapter 10. I don't remember that anymore.
Don't quiz me.
Yeah, chapter 10, you transfer all the answers to the different sections. They don't go one-on-one. and you have kind of a reasonable outline of what an advanced healthcare directive would be for you.
What I appreciated about it is this is not 30 pages each chapter, it might be 5 or 8. And then what I noticed at the end of reading these 5 or 8 pages is he said, and now this is what we talked about. I'm like, oh, that's so great. Because this can be an overwhelming chapter based upon what it was. And it's like, these are the 5 or 4 points. And then you have a series of questions after that. And every chapter was like that. So you can take a breather. And anyhow, I thought that was fantastic.
I was trying to put a workbook like we used to have in math when we were in 2nd grade. That's what.
There was there's a woman who reached out to me recently, and I said, "Did you read the book?" And she goes, "Not only I read it, went through it first, and then I went through and I went through it the second time, and I answered all the questions." And I was like, "Oh, fantastic!" What was the tipping point? What even motivated you to write this book?
So as I was leaving my primary practice, at the end of COVID, I was burnt out and I decided I've had it. A lot of my patients are coming to me who are starting to decide, what am I going to do when the time comes? And they would go see someone and they would hand them a pamphlet full of paper or a list of websites. And they had no idea how to navigate these. A lot of these patients are in their late 80s, early 90s, and they were not computer literate. And they were very frustrated. So as I'm starting to, taper off my practice, I decided, how can I help them? So I started thinking about the book, and I wrote the book. It came out about 2 years out after I had left the practice. But I've heard that some of them have used it.
And as far as when you were writing the book, was there any particular chapter that you were writing as a spouse or as a son?
So the most of the book is written 60% as the medical power of attorney for a relative, 40% as a physician. Because I thought the way doctors speak about these things, it's in code. We don't call things what they are. We don't explain the benefits and the consequences or the detriments of it. And I figured I needed to translate it so that the reader could understand what we're talking about.
That is definitely the sense that I got when I was reading it. I felt like I was having an extended 15-minute, another 15 minutes, another 15 minutes with my primary care. I felt like I'd maybe been there for an hour, and we're having just a really good conversation. A lot of these questions sometimes get cropped up. They're just too big. Like, what is important to you? And I feel as though you've peeled back a bunch of the layers and made that digestible.
That was kind of the point, is how to teach the reader how a doctor thinks about this in terms that the reader understands and not necessarily using doctor speak. So that was part of the intention.
Has anybody in your family read this book?
My mother. She shows it in everyone's face.
What did, like, besides being your best ambassador, what did she?
So, I mean, as I'm writing the book, I'm actually talking to her. She's 91. She has several medical problems, and she's made me the medical power of attorney. It turns out that my role in life, starting at 30, is basically taking care of the relatives and making decisions for them. But she basically, throughout her later years, she has talked to me about what's acceptable, what's not acceptable. She is fortunate that she is mentally very sharp. She will remember what I said to her in 1977 when she picked me up from high school and still cursed me out for it. But she's afraid. Her hearing is going. She's now wheelchair bound because she had a stroke. and now her vision is going. So she's starting to realize that the end is not far, but if it's far, she certainly doesn't want to miss the next big crisis that could take her.
So do you guys have ongoing little mini conversations?
Yes.
What do those sound like? What do those look like?
Well, my mother.
Besides that she's yelling at you for something.
No. My mom is very blunt. She'll tell you straight out, right, what she thinks and she'll see you. Oh, you're looking fat, that kind of stuff. So I likewise like to have that kind of conversation with her. But I basically say, okay, you've had this issue, you have this problem. Next big crisis, what would you like me to do? Mm. And she was surrounded by doctors most of her life, so she's used to talking about this. Mm-hmm. And she saw me struggle with, the decisions for my father and then my grandmother. So she feels comfortable addressing, and I will say to her, well, if we give you this and do this, this is likely to happen. And she'll say, we're not going there. She says, the minute I can't swallow anymore and they're talking about a feeding tube, that's the end. Next pneumonia, you may want to consider not giving me anything. I'm okay if I just fall asleep and go.
Mm-hmm. What a gift to have not just a bunch of annual conversations, but you're able to throw some lobs across the net and her as well, and make that just par for the course, so to speak.
So I actually think it's best particularly when you're talking to relatives, to have little conversations, not one long conversation, because it becomes a dreadful thing. Mm-hmm. You're talking about death during Thanksgiving, every Thanksgiving, no one wants to go to Thanksgiving, right? But if you talk about death for 5 minutes and then the rest of the party goes on, next Thanksgiving you can have the next set of conversations.
Mm-hmm. I had a conversation recently with my dad and my sister, and I got do we have to have this conversation again? And I said, I think we're building some mortal muscle. And I'm doing this just as much for myself as I am for Dad and my sister, because maybe to your point is I'm live remotely. There's probably a lot of people that live remotely from their loved ones, and my sister is the one that will have to make some decisions. And I'm like, if you mess up, you're the one that's going to need to unintubate. Extubate. And I go, I think that might kill you. And she's like, I've never thought about that. And I had the same conversation with my dad. And I'm like, listen, I know nobody wants to talk about this. I said, but your oldest daughter, you don't want to leave that on her. And he's like, I've never thought about that. So that was
particularly that decision is one of the hardest ones, because for some reason people accept that if you're down, they choose not to intubate you or shock you. It was a natural death, so to speak. Mm-hmm. But if you're unplugging or pulling the tube, now that I'm taking an active part. And what I tell patients and the families is, you are following the person's wishes. It's not you making that choice. You're just following what you agreed to do.
Mm-hmm. Which is a much more comfortable place
right.
in an uncomfortable situation. You also have pointed out in your book, I loved the language that you used. Under what circumstances would this be okay? And you also had said, if you had received CPR and you were brought back, how many more times would that be okay? And I don't know if you want to talk a little bit more about that. Quite frankly, I thought, who thinks about the second or third or the fourth time?
Well,
a cardiologist does.
Because we're the ones responding most of the time. So the more interventions you have, the more likely you're going to have complications. So if you break 2 ribs the first time you were rescued, next time you're rescued, chances are you're going to have 2 or 3 or more ribs, right? So there's a constant detriment to the body, so to speak, the more rescues you attempt. Now, if it happens that you're rescued the minute you go down, you're in a procedure and they shock you, that's not going to cause you any other than a little skin burn, right? But if you're down and you're not rescued immediately, the chances of you coming out are not great. And in spite of what Hollywood will tell you. And in the book, we talked about the statistics. If you're over 80 and you die in the hospital, or you get rescued in the hospital, you still only have about a 12% chance of survival of walking out of the hospital in good shape. That's in the hospital. Chances are that's going to happen not in the hospital, but outside. The more time that the rescue takes, the less chance you're going to have to come back intact. And the worst case scenario for many people, including my mother, would be to be on a respirator for months in pain because she has all broken ribs.
Mm. Well, also you pointed out a really key word, survival.
Right.
I've been doing a bunch of reading. And statistically speaking, is now hospitals or wherever, I'm not going to probably say this exactly, but I think everybody here is going to get the idea, is, oh no, we have an X amount survival rate, but then all of a sudden this person leaves and a month later they die. So that is the thing that I think it's how we spin things.
Well, and survival means you left the hospital. It doesn't mean you left the hospital the way you went into the hospital, okay? So you may end up in a nursing home, an extended care facility, in a vegetative state. You survived the hospital, so the statistics say you survived.
Yeah, so statistics, it's kind of like we need to kind of be a little bit smarter than the statistics. And it's like, okay, I will survive for how long? What does that look like? Yeah. Speaking of technology, how it's advanced is we have so many clinical trials. We have so many more pharmaceuticals. We have so many more devices, external and internal. How has medicine changed since you started practicing? And they call it practicing medicine, right? Yeah.
Right.
And how has that complicated or changed your relationships with patients?
So I'm a practicing cardiologist, so I really do believe in what cardiology has to offer. Okay, let me start with that. However, there's a limit to what we have to offer. Biology is biology, and there are times you just can't get around it. I think in the last 20, probably 30 years, in medicine in general, but in cardiology specifically, technology has made the big difference in how people are living and the quality of life they have. But we've gotten much better at the technology and much worse at the relationship.
I worked a bit with a medical device company, and we were developing a pulsatile flow pump when you had open heart surgery. And in this process, I got educated that your heart can be fixed, but based upon the length of time that you were in the surgery, you might have kidney failure or liver failure. All of a sudden I was like, I'm sorry, what? What? Who tells you that?
You can have pump head. We used to call it pump head. If you're on a bypass machine, people come out and they're just a little bit different, and that never quite gets better.
So what how can we be smarter to ask more questions in situations like that? Whether it's your heart or other things, like, great, if I am on dialysis for a bit of time, walk me down the road a little bit. What else should I be looking out for that it's not just that organ?
So you have to advocate for yourself. Regardless of the procedure that they're offering you or the treatment they're offering you, you have to understand what you're walking into, because overall we're going to give you a new baseline, and hopefully it's a baseline you can live with, but it's not the baseline you began. And there's nothing in medicine that will make you go from 80 to 70. It doesn't happen. You're just living in a different baseline that you can.
A bunch of people.
Well, plastic surgery may do that, but not cardiology. But no, I mean, people have to understand that it's a new baseline, and are you willing to live with a new baseline, with a new limitation? There are certain things that I would accept now that I would have never accepted at 40, right? So we all have to think that if I die in the next 10 years, I'm not going to accept this. That's why I say in the book, every 10 years you should look at just like you look at your will, you should look at your living will and say, am I willing to accept this or not? Or I'm too sick, I don't want any of this, I'm done with this.
So I got, from what you said, baseline is an important word.
Baseline. If you're offering me dialysis, how long are you offering me dialysis? And let's say that my kidneys never come back. How long am I going to live on dialysis? And what's my quality of life? Some people are willing to go to a dialysis center 3 or 4 times a week. Some people are not. If you are on dialysis, you're now limited. You can't travel because dialysis will rule. You have to figure out where you're going if there is a place that will take you. Having said that, there are cruises for dialysis patients. That they all go on the cruise and they're all getting dialyzed.
I didn't know that.
Yeah.
I want to also ask about that. We've just been talking about the heart and the kidneys, and in this day and age of a lot of ologists, a lot of specialists, when you walk in their office, they're looking at the thing that they're the expert on, and sometimes they fix the thing that's fixable, and you're left with a thing that's not fixable that might be the easier thing to want to have chosen to die from.
Well, that comes from, so a lot of people here remember when your primary doctor, whether that was a family doctor or an internist, was the gatekeeper. They controlled what happened to you. That doesn't happen anymore. The family doctors and internists have become, I guess, managers more than gatekeepers. And they send to a specialist, and the specialist does what they want, and you come back and you have another problem, you go to the next specialist. They're not the ones saying, I wouldn't recommend this because of all this. They're not analyzing the cases. And I don't think the system is allowing them to do it anyway. Because the system is controlled. I don't know about here, but where I'm at, the specialties control what happens in hospitals. The money makers control what happens. So my big frustration with medicine has been that the product, and I'm being facetious, is the patient care, right? That's the last thing they care about now. They care about the bottom line.
And it gets harder when, statistically speaking, as we get older, most of us will see more than 1 or 2 doctors for different things.
Oh, you'll never see your primary doctor in a hospital?
Right.
You'll see a hospitalist, you'll see a cardiologist, and they have no idea who you are, who you were, what your wishes are.
So I've heard stories of folks seeing their cardiologist, true story, and they've just been given some not great news, and wanting to have a conversation about pulse or DNR. And we've gotten into such the silo where that's not my job to fill that out. So you have to then cycle yourself back into the system to go see your primary care. How is it that folks can gain a little bit more agency and maybe push the issue with their cardiologist or somebody in their office and not have to wait X amount of months?
That's a touchy subject. How do you force a cardiologist to do what they don't want to do? You can't get them to agree on the same thing all at the same time. You can ask, hey, it's not that difficult. I'll fill in. All you have to do is sign. That's one thing that you can do. But most cardiologists don't feel comfortable because they see it as their own failure, that they have nothing else to offer. So since the inception of palliative and hospice, you go to hospice or palliative.
Well, let's talk a little bit about your awareness based upon your training in medical school that death seems like a failure, and talk about how much little training.
So, I've always been the troublemaker, in case you haven't figured out by now. When I was in med school, it was slightly different. People did think a little bit different. The philosophy was more like you take care of people and keep them in good shape as long as you can. But when the time comes, you also have a responsibility to say, we're nearing the end here. I don't know exactly when that changed, but it changed in my career. I was lucky enough to have an old-fashioned practice where I was a primary cardiologist. I did very little internal medicine, although I did some. But people came to me, and I knew them for generations, and I used to have 25 or 30 or 40 minutes, depending on the type of appointment. And as you got to know patients over years, you would have a conversation, but it'd be 5 minutes here, 10 minutes there. And after 4 or 5 years, you knew what they wanted. And then you'd sit down and say, okay, we're nearing the end. This is what I think you want. And you show it to them. And they'd say yay or nay, and then they would take that to whoever was going to do the document. I didn't do the document myself, but I at least told them, this is what I understood them. That's gone by the wayside. And a cardiology appointment, for the most part, is 15, 20 minutes.
Right.
And it's to deal with a chest pain or deal with the heart failure. Doctors, the young doctors don't even listen to patients. They don't touch patients. I cannot tell you how many times I see patients that have been admitted for a heart attack, that they were in the hospital for a heart attack. The ER doctor has not figured that the chest pain is chest wall pain. They put them through the whole battery of tests. They go through cardiac MRs, CTs, angiograms. They still don't know what it is. And the first thing I do is put my stethoscope on the chest, and they want to grab the ceiling. That's chest wall pain. That's not heart attack. But the patient comes in expecting to have had a heart attack. Because it's all based on, most of the medicine nowadays is based on labs. If a lab says you have heart failure, you have heart failure.
What would you say to someone that approached their doctor, any doctor, and or wanted to approach their doctor, but didn't want to be flagged as depressed, but they wanted to have an honest conversation about end of life?
I think you could, if you have a good relationship with that doctor, I think you can say, look, I want to discuss this. I've done my reading. I have a basic understanding of what I think I can, or I'm willing to agree to, and what I'm not willing to agree. But given my clinical profile, what do you think about this? If you have a good relationship with a doctor, they're willing to talk to you about it. It may not be in that appointment. They'll say, make another appointment for 20 minutes and we'll talk. Some doctors just don't want to talk about that. They'll send you to palliative or hospice to talk about that. And the reason for the book is, I didn't realize it as I was writing it, but is that my patients were not empowered to do their own research. So it was kind of empowering the patient to at least have a basic concept of what was happening.
So everybody can bring this book into their doctors and point to the chapter, like, I'd like to talk about this.
Right. This idiot said I should not have CPR. What do you think?
It is a cardiologist after all. No, it is. It's about our ability to need to have more agency and advocate in this day and age is stronger.
Either you or someone you've designated.
And so what I want to talk about is there's a nomenclature out there that I hear a lot where people say, well, it's quality or quantity. And I'm wondering, is it quality? Why can't it be quality and quantity? And you've got your chart in the book about the quality of life markers. So what is your perspective on what language would you use?
So quality and quantity are valuable aspirations if they're possible, okay? there are times, there are limitations. If you go and spend, the best example I can give you is a 90-year-old man had a small heart attack, and one of my partners offered him an angiogram. The problem was, and an angiogram is what you do to look at the arteries and make sure they don't need a stent. This guy was not going to have a bypass, but at least we thought we can do a stent. The problem was his kidneys were weak. So my partner goes away, goes on vacation. Now I have to make a decision for this guy whether I send him to the cath lab or not. So I basically had a frank conversation with the patient and his wife. I said, look, you'll survive the cath, and if we can do a stent, you'll do fine. The problem is I can't guarantee the kidneys are going to be cooperating. At 90 and with stage 3 kidney disease, you may end up in failure, and now you're looking at dialysis. First of all, getting a dialysis catheter into someone 90 is difficult. Most nephrologists will refuse, okay? But let's say everything lines up and we get you, a nephrologist is willing to dialyze you. Are you willing to live either with hemodialysis at home or going to a center 3 or 4 years? And the quality of life of someone on dialysis at first is good, but then all of a sudden it starts dropping and dropping and dropping. And the guy said, that's the one thing I'll never take. So we treated him medically, and he lived about another 1.5 years with medications and appropriate, but he was not going to have any dialysis, and he never did.
Right.
It was his call.
Right.
He chose quality over quantity. Had that conversation been had with an 80-year-old with good kidneys, it would have been quality and quantity.
Yeah, I just think that every time that we say quality or quantity, we have some preconceived idea how long, I don't know what my genetic code is. Do I think I'm going to live to 85? Do I deserve to live to 85? I don't know. I know my.
Can everybody hear okay? Some people are having trouble.
She's taking.
There we go.
Wow, that was a perk.
Well, you came to New England, so we're just trying to treat you well. I struggle with hearing quality or quantity, and I think it's just philosophically, who am I to say? But I think part of it becomes difficult when we have so much advertising, so much. You might be in a doctor's office and like, well, we can do this, or this. So it seems as though we've got this big laundry list of things that we can try, but they all might. So I'm trying to tease apart. I think it's difficult for doctors who might want to say, do you really want to go through all of those, or what kind of conversation do you want to have here? And
So I think, we all have a sense of how we're doing. We all have a sense of, I have the same energy that I had 5 years ago, or no, I don't. I find, through personal experience and patient experience, patients can tell how sick they are and how likely they are to survive something. But I think it's the patient's responsibility now to understand what that baseline is that I'm talking about, right? Is the baseline something that's acceptable? If the baseline means that I'm in a wheelchair, but I won't be short of breath, but I'll still be in a wheelchair, and I like my wheelchair, well, then that's a new baseline you're willing to live with.
right, adaptations.
Right.
That we make,
But
compromises.
if I'm expecting to jump off the table and off the wheelchair, it's highly unlikely. After a bypass, you still have coronary disease. After a bypass, you still have to control the pressures and the cholesterol and everything. We got around the disease that was going to kill you. We did not get around the problem that you're going to have chronically. And people don't understand that when you get a bypass, nowadays with modern therapy, they can last without much intervention, sometimes up to 15 years. In the old days, before cholesterol medications and the aspirins, we expected a bypass to shut down every 3 years. So by year 10, you were requiring another bypass. It was not new piping. And I cannot tell you how many families are shocked after a bypass 12 years ago that now they need another one. It's a chronic disease, so you have to understand that you are managing a chronic issue.
I think you just also gave me a little hot tip is, besides baseline, to incorporate chronic disease in my nomenclature, which I don't think we name it something, but we don't say this is we don't give it the adjective that it deserves. So people aren't necessarily thinking like that because of the language that we're using.
Well, I think the point is, health is a subjective thing. We all know someone that's 30 who thinks they're dying, that depend on all sorts of systems to help them. And we all have met 80s and 90s people that have many issues and they seem to feel they're very healthy, right? So health is a subjective thing. But as we get older, you are going to succumb to chronic diseases. And I think historically the best way to think about it is before 1960, most of us would die of infectious disease or an accident. After 1960, which means antibiotics and vaccines and all that, we started dying of chronic diseases. That's where the cost of medicine has skyrocketed because we're not dying in a short period of time, or the illness does not last 3 weeks. It lasts years. And now inflammation, which is a word you've all heard, is at the basis of everything that we're dealing with. When I was in med school, a cardiologist and an endocrinologist never crossed paths. I, as an internal medicine resident, you knew how to deal with diabetes. Once you became a cardiologist, they all went to the endocrinologist or the internist. Now I'm dealing with diabetes because it's inflammation is the underlying problem in everything that we're dealing with in heart disease. And it turns out to be colon cancers. All the cancers are inflammatory diseases.
Well, I had a couple of years ago, I went to the eye doctor, and all of a sudden, this is like, I've had glasses since 16. That's been a long time. And this is the first time, maybe it's because I'm getting older, that the doctor talked about how important eye health is, or actually how important other things are that made my eyes healthy. And I was like, I had no idea. Same thing with your dentist. And so anyhow, we're a system. And I would love every doctor to talk to us like we're a system.
They should.
I know. I know. I'm looking at you. That's not fair.
I mean, so we've established clearly that people that have heart disease are prone to gum issues. When I was in med school, we were taught that gum issues are people that took care of poor health of their gums. Not really. Okay, I mean, there are those, but for the most part, people that take care of their teeth that still have gum issues are at high risk for inflammatory diseases, particularly coronary disease. So we're tying all these things that we're learning, and that's also part of the problem. The information changes so rapidly every couple of years that we have to then, readapt what we're saying. And people sometimes look at us like, that's not what you said 3 years ago. What's this? Right? It's rapidly changing. It's rapidly accumulating. Trust me, every time I sit for a board exam, it feels like, my God, I would rather take the one I took when I was coming out of fellowship because there was 4 different questions and that was it, right? They were all easy subjects. Now the literature is so expansive because there's now an entire world of literature that comes at you, that things that you were told years ago don't apply anymore.
So for those of us who go on the www to educate ourselves, do you have, where would you point people to?
Reputable sources.
Right, yeah, well, but could you, I'm sure there's people here that know them, but like, maybe which ones should you, is it easier to say what to avoid versus where to go?
I mean, if you're going to do a Google search, for example, right? If you've done Google searches now, that the top says some AI information, right? Those tend to be actually pretty reasonable. But then you start hitting the stuff that is either paid for or commercial, where they're selling you garlic versus a cholesterol pill, right? All that stuff is where people start falling into traps. So instead of going there, I would go to a reputable source. And it's hard to read a medical journal and understand the context of the medical journal, which is a lot of the misinformation that's out there, because CNN sees this article on New England Journal, and someone reads it and they think they understand A, what the question was and what the answer came out to be. They don't understand it. These questions are, when you design a research study, you're asking one question in a population that varies significantly. So you're trying to eliminate the outliers, right? So a lot of the outcomes apply only to the one question that you're asking, not to everybody else. So you need to go to sources that will summarize this for you. And I would say the Mayo Clinic. I used to like WebMD. I'm staying away. They're saying a little couple quirky things that I don't like. There's a place called Up to Date. I think it may require a membership, but that gives you stuff that doctors go through and how we think about things. You can go to Hopkins, you can go to Harvard, Cleveland Clinic, all these. I mean, if you're looking for specific questions, that's where I would go, unless you're medically trained. Medical journals, I mean, people don't understand. I remember we had lectures in medical school for statistics. Then in residency, we had to go through statistics to understand the questions. And then you would be put in front of your entire classmates in residency to analyze a study. And the statisticians were in the audience criticizing you. That was a teaching method to get you to understand what the statistics meant, what the questions were being posed. So it takes a long time to learn how to read one of this and understand the specific questions. People read the conclusions and think that's the answer to the study. That's not.
Well, I just think it's hard when we want to educate ourselves.
Yep.
And we don't want to, let me rephrase, we would like to come prepared to medical appointments and to have some credibility, as I've done a little bit of reading. And it's not WebMD, it is Cleveland Clinic. I have some questions. And I didn't know if there's any other suggestions.
Well, I think what you said was correct. I've done a little reading. Okay, that's the question. That's the way you approach it. You say I've done some research. It means you did a Google research, right?
Yeah, reading.
Right.
Reading people.
Google searches are Google searches. They don't give you the answer. They give you snippets of the answer. And yes, we fully understand that aspirins are good to take if you have established coronary disease, but until recently, maybe 5 years ago, we gave aspirins to everyone, right? Until we realized, ooh, we're causing more GI bleeds. We have to stop. So now we only give aspirins to people that have established coronary disease. But it took years, but people don't understand that there's a reason why we're coming, adding things and all of a sudden taking them apart.
Right. I guess I just want people to know when they leave here a way to approach their medical folks. So don't use research.
Use reading. And go to reputable sources.
And just say, I'm trying to educate myself so we can have a meaningful conversation. Right. As opposed to just have you tell me in a very compressed amount of time. Another thing that I loved about this book, early on page 15, you brought up money, finances. And I this guy's the real deal. That you are willing and able to put some ink in your book where I've not seen, I don't think I've seen anybody talk about the reality of that. Why was that in your book?
Well, because I've had patients that have used up their entire life savings on their way out, and the spouse is then left destitute. And I mean totally destitute. People do not understand that all the procedures and everything we offer is approved by the insurance company or Medicare or Medicaid. It depends. And I think in medicine, like everything in the country, we all like money, we all want to have more money, but we don't want to talk about it. It's considered rude, it's considered poor taste.
Let's take a toll. How many people want to talk about money here? All right, a few, right, yeah.
And it's an important thing. I mean, we're in a society that we don't take care of our people who are homeless. We don't give health care to people that don't have health insurance. They are, if they land in an ER, they have to be taken care of. It doesn't mean they're going to get admitted. It doesn't mean that once they leave the ER or the hospital, they may be going back to the street after you spent all that money taking care of them. So we don't live in a society that supports individuals unless they support themselves. So if you're planning your retirement, you need to be thinking also, what kind of money would I need for certain procedures, and how much am I willing to spend, given that in my case my spouse is going to outlive me by 25 years. So I cannot use up all my money and leave them totally destitute. And people, was it you that I was telling my father's bill? So my father's last bill, my father died when I was young. I was in my 30s. And it was 1993. I'll never forget. He had insurance. Everything that he went through was approved. I'm a doctor by this point. I opened the bill. He spent 40 days in an ICU. It was $1.5 million. Till this day, I still remember how close I came to hitting the floor because my knees were. I mean, I was like, how is my mother going to pay for this? Then, oh, that's right, he's approved. They were just letting me know what the total cost is. And that was 1993. You can imagine what 40 days in an ICU would cost today.
I find it very empowering to bring money up to my medical professionals. It's like, how much is that going to cost? And typically, they get, I don't know, because that's a different department.
Well, the truth is we don't know because they keep changing it on us.
I know.
They keep changing. I mean,
Yeah.
you put in a code, and the next thing you know, that code is inappropriate. Now you put this other code, right? This other code is what happens. And what people have a hard time, when I started my career as a cardiologist, I used to do angiograms. And one day a patient comes in and says, I cannot believe you charged me this much. And he brings the hospital bill with $17,000 for the angiogram. It happens that day they had paid me for what I had given, for the procedure. I happened to pull my check. I said, this is what I get for this. It was $125. Everything else went to everybody else.
That is going to be part of this video that's going to go viral. I've filling out your advance directive, doing all this paperwork, and imagining and trying not to get wrapped up in future thinking. I'm right now early 60s. Maybe I'll live another couple decades. I'm just trying to think in 5-year increments, not 10, 5. And I've put in my advance directive that anything over 50 grand out of pocket, don't do it. And my partner is like, really? I go, I only have so much money. I do not want you walking this earth after this and I'm dead and you made a lot of decisions out of guilt. Right. Or out of misguidedness. It's like, no, I'd rather you say, all right, I got some extra money. Thank you, Laura. And it was on my terms. But it's this weird thing to bring up money. And I'm not putting the value of my life at 50 grand. I'm just trying to tease apart the realistic way to try to figure this out, knowing in 5 years from now, it's going to be more complicated.
So I kind of agree with you. I just don't think that saying
50 grand's not your number?
No, I'm saying it's 50,000. 10 million for me. No, I think it has nothing to do with value of life. Right. I mean, it's acceptance of the finality of what we are and who we are, and then deciding how much more do I want to try to save it, right? Because one thing is very true. If you live a long life, there are certain things lined up to get to you. I mean, people don't think of it in those terms, but the most logical thing is a lot of us remember when people used to break hips, they would not do surgeries and they were dead in 2 weeks. That's biology speaking. You break a hip, you lay down, you now have a clot in the leg that moves to the lungs and kills you instantly, right? Now we've gotten past that point.
Well, I think that's a hot tip for anybody that breaks a hip. And it is I'm joking, but I'm not.
But it's very painful.
You know,
It's very
it's like
painful.
there's so many off ramps that we don't talk about.
Right.
Um,
I mean, pneumonia used to be the old man's friend.
yeah.
Because the pneumonia got you, you were going to die. And I still remember when lung cancer was a terminal diagnosis, no matter what it was. And early in my career, there was a gentleman who was diagnosed with lung cancer, and I think it was small cell. And there was no cure. It was a lot of chemotherapy. We both knew nothing was going to work. So he said, look, I'm going to spend my last 6 months with my family. I'll come back when I need pain relief. Disappeared for 6, 7 months, comes back. We hang the morphine, and he was dead in 2 days. But he enjoyed whatever time he was left. Didn't go through the torture.
I'm recently, in the last 3 years, getting into the end-of-life realm, learned that pneumonia is the way a lot of people died. That's one of those first things that we fix.
Yeah.
And there's a selection of folks that I have conversations with as an end-of-life doula, and they share what is quality and quantity of their life at the moment. And I'm like, okay, so again, as part of the socialization is, keep in mind, if you get a UTI or if you get pneumonia, you might not want to just jump on fix me, because that might be, you need to hit the pause button and just say, should I
That may be the
address
better
this?
way to go.
Yeah, that could be.
I mean, if you get septic, your pressure drops, and you just fall asleep and you go.
Oh, I didn't know that. So I have a couple more questions, and then we're going to open it up to the audience. Advanced directives. Your book is a beautiful guide to hopefully at the end or at any point in there say, oh, I think I got enough to legally fill out my advanced directive and share it with somebody. How important are conversations versus the paperwork?
So the conversations are key. That's actually the most important thing. Paperwork is in case you have difficult family, difficult dynamics, no one to help you, you've not had a medical proxy, then the paperwork becomes important. But if, for example, if you have 3 children and they're all in agreement, they're going to follow your wishes and they all understand your wishes, you may not need a living will, except if you are out of state and something happens, you may need that. By the time your children come around or they find your children, it may be too late, right? That's one thing I will tell you. If you travel, take a living will with you. I even tell my biking friends, we should all carry copies of each other's living wills when we're biking.
Cool.
Because it is an issue,
Yeah.
right? But if your family's all in agreement and they all understand, the paperwork is secondary, unless there's something that you absolutely will not take, dialysis, for example. But I have seen families that seem to be all very cohesive and homogeneous until the S hits the fan, and then all of a sudden it's a fight. And if it's not clear, no, he said last Christmas that he wanted this, or 2 years ago she said, then it becomes a fight. So that's when the paperwork becomes, paperwork is where the doctor who's going to follow your wishes is going to hang his hat on. Otherwise, you're going to be intubated and rescued and everything done because they're not going to take the fight with the family.
How do you acid test your family?
I can't answer that one. I'm not a family specialist. I mean, you have to talk to your children and make sure they understand. A lot of children do not want to deal with it. And somehow you're going to have to get through to them. And if you're not, I remember a friend of mine said to his family, if you don't want to talk to them, I'll assign someone who will be your medical proxy, then I have nothing to do with it. And all of a sudden, mom and dad, no, we want you to do it, right? You sometimes have to take a somewhat adverse position so that the family is willing to talk about it.
How many people, in your experience, and there's probably no one story about this, but how hard is it for spouses to be the primary versus children, or
So it depends on the family dynamics, okay? If the center of the family, the alpha person in the family, is the one that's dying, the spouse may not be ready for it. Then one of the children would then have to be there. But that can be determined ahead of time. There are spouses that cannot deal with the death of, because they are the ones suffering the biggest loss. The person dies, now their life has changed drastically. But my experience, I would say 94% of the spouses are willing to follow the spouses, except one case.
that you know of.
Well, I was a fellow, and there was a heart attack, and I had to get permission from the wife to take him to the cath lab, and she refused. He said he was a bastard to me my entire life. Let the effer die. So here I am, a fellow. I can't make that decision. So then I had to call the president of the hospital to give me permission to take him to the cath lab.
Wow.
So that can happen, but that's only one.
I have something similar but not. As I was filling out my advance directive, I have an undocumented spouse, not married, and I have an older daughter in her 30s, and I chose my undocumented spouse as my primary, and I'm having a conversation with my daughter, and I explained, I shared in advance, it's like, Jeff is my primary, and she said, oh, why is that? He won't do what you want. And yes, I know this is being videoed. And I said, well, what is it that you think I want? And there was a little bit of a pause because in all fairness, we hadn't talked about it. And I said, well, let me just explain what I've been teasing apart and that I shared with him. And let me share that with you. And after I did, she goes, you don't want that. And I said, that is why you're number 2. And I said, I think it would be so hard for you to let me go, regardless of our ups and downs in our relationship. I wouldn't want that on you. I would love for you guys to be a team, but I don't want that sole responsibility on you. And I want to keep having these conversations so it's not a surprise and you're not forgetting what was going on.
Yeah, I actually designated my spouse's niece who will follow what I want. And that was a fight that took 2 years to get over. But I said, no, you're not going to follow what I need. She will follow the letter of the law.
Because there is, it's not just saying yes. It is sometimes being in a medical situation where there's a lot of jargon. There might be somebody who is better suited to understand that. So you might have somebody, I think this is all a little bit of a team effort.
Right.
Is you might have the person who's like, I will advocate for you, but I might get really confused with all these options. So
there's a 30% chance of survival. That kills me. 30%, really? We're gonna take that chance? No, if it's not 70, I don't want it. Right?
And then we know, because we've had this conversation, I don't want to just survive, I want to thrive.
Right.
So what does that look like?
Right.
Right?
Well, I mean,
Oh,
I used to be deadly afraid of flying, okay? And the funny thing is I don't recall my first flight because we moved all over the world when I was a child. I've lived in 29 houses in my entire life. And then I went into medicine. And then I realized everything that can happen, lost my fear. The more the plane shakes, the better I sleep. Because I figure it's 30 seconds down.
I do want to bring up, we had some folks submit questions when you registered. And I know we talked about advance directive, healthcare proxy. Let's talk a little bit about when you're a solo ager, or you are not a solo ager, but your family lives in many zip codes or time zones apart. What advice would you give for somebody in that situation?
So
Or
for the
those
solo
two?
agers, I would turn to whatever community you have, whether it's the church group, the community center, whoever it is. There is someone either in your age group or younger, a child of a friend, for lack of a better example, that could serve as your guide. Because mom is fond of you, so therefore the daughter would be happy to serve that. Ideally, your healthcare proxy should be relatively near. An hour or two will be fine. But beyond that, it gets very difficult because a lot of decisions have to be made like this. And if you're not around, they're going to choose something that you were not agreeing to. So my family lives in Pennsylvania. I could not choose my family. I had to choose my spouse's family for mine for that reason. Unless I end up moving to Pennsylvania, then I'll change all my wishes. The solo ager is the most difficult case because you have to find someone in your community, and we all have a community, whether we think about it or not, that someone who's willing to help and who you trust.
And that could just be for the next 12 months.
And it could
It
be a
doesn't have to be
chaplain.
for 10 years.
And it could
just
be your
like-
chaplain. It could be a deacon
Yeah.
in the church. It
Yeah.
could be someone like that who's willing to follow your wishes.
I think you already touched on it, but if there's anything else, is when anybody is delivering uncertain news,
Right,
which is tricky.
right.
How best for the person receiving this uncertain news, if you were to give us 2 or 3 things to think about, I think we've probably covered that, is, okay, instead of surviving, instead of fixing, what does that look like? I'm just like, what pillars of questions that we could just put in our back pocket for if?
So, I mean, the first question I would ask, let's say someone says to me, you have this kind of diagnosis. And there are certain diagnoses in medicine, not many, but there are certain diagnoses that what they're offering you, let me go back. So statistically, if what they're offering you is better for you than the option of not doing something, i.e. a bypass, and you're in the right age group and all that, then I would choose the bypass because it will change your morbidity and your mortality. Your quality of life will change drastically after the 3-month period after the bypass. There are a lot of other things, and keep in mind I'm a cardiologist, it's been a long time since I've done a lot of other medicine, that it can be questionable. If it's just a treatment to give you quality of life, I would do it. If it's a treatment to extend life and you're not really willing to live another 15 years, then you have to think about it. The best case example I can give you is a pacemaker. When I was young, I thought the pacemaker was the worst thing. Why? Because it kept people alive. And as I practiced cardiology, I realized pacemakers do not extend life. They actually maintain quality of life. Why? Because if you're not falling and breaking bones, you're going to be in better shape. People that decline pacemakers end up breaking hips, arms, skulls. The way out is a very difficult way to go.
Right.
Okay, so choose the pacemaker because you're only going to make your exit more difficult if you don't choose the therapy. But you have to ask the right questions.
What about, I love the question that I've been socializing recently, is what if I do nothing? And can you walk me through that?
So perfect case, the pacemaker.
Yeah.
You do nothing, you're looking at maybe 18 months of breaking bones, going to the ear, setting the arm, setting the jaw, setting the hip. I'm a chicken, I'd rather not die in pain.
Right.
Right?
Right.
I mean, and 18 months of pain is not something I'm looking for.
Right. Right. So one more question, and then we'll throw the mic out into the audience. What would you, if you were to give people 1 or 2 tidbits or tips to start conversation with their loved ones or friends, what would you suggest?
That's tough. Well, I think it depends on your relationship with that person. But if you have someone that you want, and I'm assuming you're not talking about a diagnosis of death.
No, this is just, oftentimes, people who show up to the Pre-Dead Social
Right.
Club is because they don't know who else to
Well,
talk to.
So I think
yeah.
you have to, when you're talking to a friend or whoever you think you need to talk to, you gotta say, look, this is important to me. I want you to hear what I have to say. Whether you agree or not, I understand, but it's not gonna affect my perspective on this issue because this is a very personal thing. And that's the key. I mean, we all suffer the benefit of the consequences of our negligence or our proactivity, right? So if they are truly willing to listen to you, they'll listen to you. They may not like it, but they'll have to accept it. And hopefully they'll come around to understand your perspective on the issue. So I would say, this is important to me. I want you to hear me.
So what I heard you say is start with yourself.
Yes.
Yeah. As opposed to what is important to you, Luis. Start with what's important to me
Right.
to share with you. Thank you. Or maybe a round of applause.
Thank
Thank you.
It's kind of embarrassing, but thank you.